Thank you for joining our Debbie's Dream Foundation webinar series. Today's webinar features Dr. Chul's presentation is on the prevention and early detection of gastric cancer. I am Jen Higgins-Spires, Programs Manager for Debbie's Dream Foundation, and I will be moderating today's webinar. Thank you also to our generous sponsors for making today's program possible. Platinum sponsor Astellas, Gold sponsor Merck, Silver sponsor Daiichi Sankyo, and Bronze sponsor Arcus Biosciences, and friend of DDF Taiho Oncology. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation on gastric cancer prevention and early detection strategies from Dr. Hyun. A question and answer session will follow the presentation. Stomach cancer is the fifth most common type of cancer and the third leading cause of gastric cancer death globally. In 2025, approximately 30,000 Americans will be diagnosed with stomach cancer, and nearly 11,000 will lose their lives to the disease. The overall 5-year relative survival rate is 36%, dropping to just 7% for stage 4, highlighting the urgent need for increased awareness and research. Stomach cancer also disproportionately affects minority populations with Native American, Black, Asian, and Pacific Islander and Hispanic communities, and experiencing significantly higher mortality rates compared to the white population. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness, providing resources, and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23, 2017, at the age of 50 after a 9.5-year battle with cancer. As an organization, Debbie's Dream continues her important work and legacy. In a few short years, Debbie's Dream has achieved many great milestones. Our mission ambassadors provide outreach throughout the country. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We have also provided $2 million in research grants to date. Patient advocates come together each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program, also known as the PRCRP, which allocates funds for stomach cancer research. Earlier this year, in February, we traveled to Washington, D.C. with nearly 200 advocates and held over 180 meetings with lawmakers to inform them that we need more funding for this deadly disease. We are proud to say that this year was our largest turnout yet. We hope you'll join us next year as we continue to let Congress know that we need a cure. You can type your questions throughout the presentation into the chat section that appears in the webinar menu. This function should be at the top of your screen. We address questions at the conclusion of the presentation as time allows. So there are 2 places you can add this, the chat feature and also the questions box. They're both at the top. One has a question mark in the middle of it. And now to introduce our speaker. Dr. Chul Hyun is a renowned medical professional with extensive and academic clinical credentials. He earned his degrees from prestigious institutions like Johns Hopkins University and the University of Miami. He holds a PhD in biophysics and an MPH. His career includes fellowships at Yale and the University of Chicago, and he is board certified in gastroenterology. Dr. Hyun served at Weill Cornell Medical College for over 2 decades and has held influential leadership roles in medical organizations. Currently, he publishes Next Biohealth, mentors young physicians, and directs Yale's gastric cancer prevention and screening program focusing on early detection and reducing health disparities. Let us now begin our presentation with Dr. Hyun.
Okay,
Okay.
I'll have my, I guess, first slide.
You should have remote access now.
Okay, take a remote control. Sure. I clicked on the remote control. Do you see the screen right now? I
Right.
don't see.
I can forward the
Oh, there we
slides.
go. Okay, all right. Okay, hello everyone. Good evening or good afternoon, depending on where you are. It's 7 o'clock here and where I am at New Haven. And thank you very much for joining us. And I also want to thank DDF for inviting me to give this important talk on prevention and the early detection of gastric cancer. Uh, Before I begin, I just want to just say a few things about myself. I was originally from Korea. I was born in Korea. I grew up there until I was like a 13, and then I went to actually junior high school and high school in Taiwan and Japan before coming to the United States to go to college. So my school journey was between 73 and 92. And after my fellowship training at Yale, I took a job, originally actually at academic job in New York City. And I was, doing mostly actually, basic science research and seeing patients maybe about 20% of my time. But then I started to see increasing number of patients who were coming to see me with advanced gastric cancer and advanced, liver cancer and liver cirrhosis. So then I found out that there was a strong demand, for, this care for many of these issues that actually arise from health disparities. So actually, I ended up going out to private practice, and where I had a practice in New York City and Bergen County, New Jersey, for about 30 years. While I was serving the patients in a private practice setting, I did, organize a couple of nonprofit organizations, one of which is the Stomach Cancer Task Force, which, of course, the vision and the goals and the, mission kind of aligns with DDF's mission and goals in raising awareness about the stomach cancer and then finding, early detection and the cure for this deadly disease. Last year, I returned to Yale to launch a program called the Gastric Cancer Prevention Screening Program, as Jan already explained, which has important purposes that I'm going to summarize in a few minutes, actually. So I'm going to try to make this talk as informal as possible. So feel free to jump in. You can throw in the chat and ask your questions, and so that we can, uh, sort of like a go as informal as possible. Next slide. Let's see. Okay, is this not moving? Let's see. How do we advance the slide? It doesn't work this way.
There's an arrow. If you put your cursor, you should be able to see the arrow toward the left. If not, I'll advance them for you.
I don't see the arrow here actually. on the left.
All right. Yeah.
Um,
I,
Actually, when I do this, it should come on, but it didn't.
I can I can do that for you.
Oh, maybe. Oh, right there we go. Okay, I see that. Okay. Okay, so this was DDF's Advocacy Day in February 25th. And was it 25th? 26th. And actually, one day I joined them, and it was really amazing experience. I was there for about 6 hours, visiting, many of the Congress members' offices and speaking to them, and walking around with many of the DDF's members, some of whom probably are joining this webinar. And it was really kind of like moving and inspiring to see, kind of the hard work that, the members of DDF put in, and dedication and the passion, and trying to, raise awareness about this, deadly disease, and trying to, bring some meaningful change to the community. So it was really great to participate, although it was just one day, and it gave me a lot of learning. Last week, actually, I gave a group of students a talk, and medical students here, and I was telling them about awareness and the knowledge. The difference between the awareness and the knowledge. And when we talk about in medical, science or in medicine, when we talk about, knowledge, we're talking about, like say knowledge about the disease. We're talking about, the pathophysiology of the disease, mechanisms of the disease, and how to diagnose it, and how to, apply a certain, diagnostic tools, and medical and surgical treatments. So knowing all of these are sort of like a, knowledge part of it. But the awareness part is something different. Awareness is something. It's like maybe in one phrase we can sort of summarize this as being sort of like a conscious of what the disease is all about, being conscious about what disease means to an individual, to family, and to society and community in general, and the impacts that brings. Now, this awareness part is not something that uh, they teach in medical school or in any training. It's something that you experience and you earn, actually. And without the awareness, what is knowledge for, right? So it's knowledge is like a toolbox with all these great tools in the box, and the awareness being a way to actually apply those important tools that we have. So joining this event and working with the DDF and other, patient advocacy organizations actually, taught me a lot, brought me to a, different horizon in the awareness, scape, landscape. So it really was really interesting. So I wanted to kind of share that with you. Let me see. Let me find the arrow here. Mm, to advance the slide. I see it. Okay, there we go. Okay. Um, just some important statistics about gastric cancer. Globally, it's the fifth most common cancer. We all know that, and it's fourth leading cause of cancer death. But in the U.S., as you said already, Jan, there are only about 30,000 patients annually, right, that being diagnosed with the stomach cancer, as compared to, for example, how many colon cancers are being diagnosed every year? Probably about 150,000. And there are over 300,000 breast cancers diagnosed every year. So in terms of the number, it's a small, but globally, it's a very serious disease. But considering the U.S., if you look at the specific populations, especially immigrant populations. But before we speak of immigrant populations, different ethnic populations, Asian Americans, Hispanic Americans, And African Americans, they have a very much higher, prevalence of this disease. And I'll show you some numbers in the later slides. The 5-year survival rate, as ACS reports, for example, is about 35, 36%. That's the most recent number. And But that is a stomach cancer all combined, by the way, meaning not only adenocarcinoma, which are mostly in intestinal types or diffuse type, but but there's a stomach cancer like lymphomas. There's and neuroendocrine type of tumors in the stomach as well. So all these cancers combined, the survival rate is 35%. But if you look into uh, adenocarcinomas only, the survival rate is a lot worse than this. And that a lot of people don't know actually. It's only about 25%. So anyway, the reason this survival rate is so poor in the US is because most of these diseases, maybe 60%, if not 70%, are being diagnosed rather late. And only like a small, like a quarter of the diseases are diagnosed at early stage, which have a potential for cure. So this is a contrast, with the statistics that we have from Japan and Korea, where 75% of cases are diagnosed early, and that's because they do have a national program, a screening program that they carry out from 20 years ago, and so that this lack of routine screening program in the U.S., even for high risk populations, it contributes to really these poor outcomes. So there are many challenges that we have. It's like I said, it's being diagnosed late, leading to poor survival rates. So unlike a colon cancer, there's no routine screening program in the U.S., not even for high risk populations. No doubt, early detection will improve outcomes, right? So the guidelines are not out there yet. For example, if we turn to guidelines, we look into, for example, U.S. Preventive Service Task Force guidelines. They don't have guideline or recommendation. There are three major gastroenterology societies in this country. One is AGA, American Gastroenterological Association, and the other one is ACG, American College of Gastroenterology. They are coming up with guidelines and suggestions and recommendations as to what we should do, recommend to physicians and the public. So we're recognizing at-risk individuals, and I think as we recognize these at-risk individuals, I think it will help to guide screening decisions. So I'll talk a little bit about that because that's the only way, I mean, the best way that can lead us to early detection and also to prevention as well. Next slide. Okay. So who are considered high-risk patients? Well, I mean, the first generation immigrants from high incidence regions, which are East Asia, like Japan, Korea, China, Mongolia, Eastern Europe, Central and South America, and some Middle Eastern countries. Well, individuals with, the first degree relative with gastric cancer, like, fathers, mothers, brothers and sisters who have had a gastric cancer, or, they are clearly a high risk patients. And also patients with hereditary cancer syndrome. Uh, I met some people actually in Advocacy Day who had family members who suffered from hereditary diffuse gastric cancer with a CDH1 gene mutation, plus Lynch syndrome and other familial cancer syndromes. They are, they also belong to a high risk patient group. So this Data comes from a publication of one of our colleagues who looked at different ethnicities from California. Actually, this is data from California, age 50 and above. Uh, First, I should mention that stomach cancer is largely divided into two different types. One is a cardiac gastric cancer. The other one is non-cardiac gastric cancer. So cardiac gastric cancer is the gastric cancer that occurs very close from the GE junction or gastroesophageal junction, whereas all the rest is belongs to non-cardiac. So non-cardiac is probably about 75% of all gastric cancers are non-cardiac gastric cancers. So if you look at the cardiac gastric cancers, there is really no significant difference among the ethnicities. But if you look at the non-cardiac gastric cancer, which Helicobacter pylori is an important risk factor, and I'll talk a little bit about that. And because I know that DDF is very interested and keen about the screening H. pylori, in the high-risk population, for example, veterans, VA populations. I think those are, so I'll bring that up in a few minutes. So if you look at the major type of gastric cancer, which is a non-cardiac gastric cancer at the bottom, you will see 50 years and age 50 years and above, making non-Hispanic white as 1.0 reference point. You will see that some Asian groups have almost like a 7 to 10-fold higher instance of gastric cancer. Now, this is kind of interesting if you look at the Koreans and Japanese. Here, we're talking about Korean Americans and Japanese Americans. If you look into data in Korea and Japan, for example, the instances are very same. They're very similar. But yet, in America, you see the Korean Americans have a much higher instance than Japanese Americans. And the reason is because a lot of these Japanese Americans are second and third generation Japanese Americans, whereas majority of these Korean Americans are first generation immigrants. So there's a difference on that. Okay. So how does uh, gastric cancer occur? I mean, so this shows a what we call Korea cascade, named after Dr. Korea from Vanderbilt, who basically, showing here in this diagram, this is actually modified the Korea cascade because this this is a sort of like a model, just a framework that sort of summarizes sequential stepwise steps, I guess, sequential steps from normal mucosa to gastric cancer. And at this, when Dr. Correa actually proposed this model in 1970s, we didn't know much about Helicobacter pylori. Helicobacter pylori came about in 1980s, early 80s actually. So this is in a way a modified Correa cascade, you can say. So let's look at the normal gastric mucosa. Uh, when there is Helicobacter pylori infection, it will develop chronic active gastritis. And if left alone, and in other words, not treated, it will it can develop into atrophic gastritis, and then intestinal metaplasia, and then low-grade dysplasia to high-grade dysplasia to gastric cancer. Of course, not everybody with chronic gastritis or atrophic or intestinal metaplasia will develop gastric cancer, but as years go by, the chance of developing the dysplasia and gastric cancer does increase. But that is an important fact. The Helicobacter pylori step can be anywhere where I put these steps here. And so if you were to eradicate Helicobacter pylori, it will help. It will help immensely, depending on when you actually eradicate H. pylori. So it's a common stomach bacteria. It's actually group 1 carcinogen designated by WHO. And it's it can cause a chronic active inflammation. And like I said, if you eradicate Helicobacter pylori, it can actually help to reduce the risk in that pathway. The thing about the Helicobacter pylori is that most of the people who have infection do not have symptoms. So you will never know unless we test it, actually. Uh, this is one of the things that we're trying to do actually at Yale, that we're trying to reach out to the community and screen Helicobacter pylori in high-risk populations. A lot of data that we have in this country are all retrospective data that come from the hospital or huge academic centers. Uh, so the importance of a study like this is going to be sort of like a real-time data where you reach out to the community at the high-risk population and screen Helicobacter pylori and demonstrate their lifetime instance or prevalence of this infection. I think that will help to, for a lot of things, as I summarized here. This is you don't have to be a clinician, but let's just think about this case. So we have 52-year-old Japanese American man presenting with just for routine checkup. He's not symptomatic, but has his father who was diagnosed at age 60. What would you recommend? What would maybe the most appropriate next step that doctors can recommend? A is no further screening. That's because he's not symptomatic. Well, this doesn't sound right, does it? Right? B, Helicobacter pylori stool antigen test, and if a positive, eradication therapy. Well, it's a possible. Okay, it's not a bad answer. It's possible. C, EGD, upper endoscopy for gastric cancer screening. D, genetic testing for hereditary gastric cancer syndrome. E, CAT scan with contrast. Which one would you pick? You probably will think about, oh, maybe it's B or C. So in this case, no question, it should be C. This is easy. I made this question very easy because this person has family history, first degree relative with gastric cancer history. So whether he is, American, white, non-Hispanic white, or wherever he comes from, it doesn't really matter. He would be a good candidate for upper endoscopy for gastric cancer screening at his age. He's 52. Um, what if he did not have a father diagnosed with gastric cancer? He's not symptomatic, he doesn't have a family history, and he is a Japanese American man. Then you may ask, wait a minute, is he first generation? Is he second generation? Or is he third generation? Or, and what other symptoms? Well, he's asymptomatic, so I guess we don't need to discuss that. So in that case, what would you think? If it's a first generation or a second generation, a Japanese American, probably I would still go with upper endoscopy for gastric cancer screening. Now, what I'm saying here is not in print. It's just I'm just presenting this case for us to think about it. That's all. There's no correct answer for this. We don't have guideline that says this is what needs to be done. there was a publication January 2025 this year in gastroenterology that we call AGA, a clinical practice update, which actually suggested somebody like this, even without family history, if he happens to be the first generation, he probably should be recommended or considered for recommending uh, upper endoscopy for gastric cancer screening. So it so if this is Japanese, not Japanese American, and he happens to be Hispanic American immigrant from Mexico, what would you do? Would you go directly to the upper endoscopy, or would you go to the Helicobacter pylori test first? So now that's there's my thinking would be to go to the Helicobacter pylori stool antigen test first in that case, because the instance in Mexico or Latin America is not as high as the instance that you will see in East Asia, for example. But again, this is my individual approach on the basis of what uh, the societies or currently come up with as far as recommendations are concerned. Let me see. So this is sort of like a drawing that's what we're trying to do. I think what DDF is trying to do, what Stomach Cancer Task Force is trying to do, what the gastric cancer prevention at Yale, is trying to also do is trying to do the awareness campaign, educate public healthcare providers, and such that the people who are at high risk should be screened. So if you follow this primary prevention will be if those who are at the high risk, if they have a Helicobacter pylori, they should be screened, and if they do have it, they should be eradicated, right? The Helicobacter should be eradicated. And then further assess this patient, and if necessary, this patient may be scoped, may receive upper endoscopy, and that would be the secondary prevention. And so I put this as a cycle because as we do this, we will learn, it will be updated by the data that accumulated. And we'll make better strategies, better recommendations, and better guidelines as we go along. So I thought I'd show you to define the primary prevention and secondary prevention in this thing. Okay, well, let's go back to the previous slide. Oops. Can I go back to the? Okay. So just very briefly about the gastric cancer prevention screening program at Yale. What we are trying to do, we're trying to do a lot on education, especially to healthcare providers, because I have learned so much in the past few months I've been here that many physicians are not aware of these risk factors with H. pylori, with gastric cancer. So it's very important that the healthcare providers become updated. And also, not only the primary care providers, but also the specialists. They need to be able to recognize when they, for example, examine the patients or scope the patients, be able to distinguish, what the precursors to gastric cancer look like endoscopically. So this part of the training, I think, is very important. Community outreach and community education, I think, is another key factor, so that when people get educated and become aware of this disease, and they will seek out their care. They will approach the healthcare providers, and they'll be more vigilant about what they could potentially have. And I think we have to work on, as DDF is working very hard on, healthcare policy advocacy, and with all these different organizations, and trying to collaborate internationally with other organizations. So this is what we're trying to do at the Yale's Gastric Cancer Prevention Program. This is just quick reminder for everybody. I think what we can do is know about our risk, our family risk, and talk to our physicians. And I think it's important to ask about the Helicobacter pylori testing and endoscopy. Share what you learned with your friends and the family members, and support the advocacy and research efforts that you in your community. Thank you very much, and I hope to entertain some of the questions that you may have.
Yes, thank you very much, Dr. Chul,
Yeah,
for this really great presentation. Some questions did come into the chat. At what age do you recommend EGDs for someone with a family history of like a father of stomach cancer, no hereditary genetic markers? Is it more of a concern at older ages? Thank you, Laura.
yeah. Um, okay. It depends on if you're speaking about the family members. It depends on uh, what kind of disease that is, right? I mean, if it is, for example, CDH1 gene mutation disease, that's very serious because that patients need to be screened right away. But if let me tell you what they do, for example, in Japan and Korea. They do, starting like 20 some years ago, they start screening every other year uh, biannually with upper endoscopy from starting age 40. So I think the American Gastro Association and some of the other GI societies are coming up with a recommendation that if we were to recommend for high risk population, who are asymptomatic, of course, then we can screen starting age 45 to go along with the colon cancer screening. So this has been discussed and actually written about. Mm, any other question? Next question.
Yes, yes, definitely. And this is from Mary. Is H. pylori bacteria not as present in the US? Why are second generation Americans not as affected?
Okay. Why are the second generations still at the high risk if they don't have H. pylori? Is that what the question is?
I think it's more like if why H. pylori is not as present in patients in the United States, and so why are second generation Americans not as affected?
Okay. Well, let's put it this way. Helicobacter pylori is just clearly a major risk factor, but that's not the only risk factor. That's not the only, that's just one of the many, many causes. There are dietary factors. There are other environmental factors that we have to include. So when you look at their studies, they're showing, for example, Japanese and Korean immigrants, the first generation and second generation, the instance of gastric cancer in, for example, in second generation Korean Americans is much lower than the first generation. And it can be explained by clearly, I mean, the significantly fewer, H. pylori infections in the second generations. That clearly is, one explanation. Plus, dietary factors have significantly changed as people immigrated into the different country and live there. There's a big difference in that. So I think we saw that with the colon cancer with the Japanese immigrant populations. The first generation Japanese Americans, for example, will have colon cancer instances similar to their natives in Japan, whereas the second generation, Japanese American for example, will have much higher colon cancer incidence than their, Japanese natives in Japan. That well, again, these data are like 20, 30 years old already. But so there are, clearly not only genetic but environmental and the dietary factors that are involved. So let me tell you this: there are many other nations throughout the world who have very high instance of prevalence of H. pylori infection. If you look at India, for example, and the countries in Africa, I mean, more than 50% or 70% are infected with a Helicobacter pylori. Yet the gastric cancer incidence is very low. So, well, of course, that can be explained by the fact that Helicobacter pylori is not only one guy. There are different There are different, H. pyloris. One is there are some are more virulent than others. I'll put it that way. So that's one of the explanations. What I'm trying to say is that Helicobacter pylori doesn't tell everything. And also, I showed you the cascade earlier. If you were to treat the patient with a Helicobacter pylori to reduce the chance of the gastric cancer, you want to do it as early as possible. For example, before intestinal metaplasia settles in. Because once intestinal metaplasia settles in, even if you eradicate Helicobacter pylori, once the cellular changes take place and dysplasia may take place after that. So it's a Helicobacter pylori is not going to reverse, for example, intestinal metaplasia to back to normal tissue. Whereas at the first step, the normal mucosa to the chronic inflammation, if you treat Helicobacter pylori, there's a very good chance that the chronic active inflammation will go away and it will reverse to the normal, gastric mucosa. So Helicobacter pylori, I think, prevalence of Helicobacter pylori in this country is very low. So that's a clearly an important reason for lower instance of gastric cancer. That is for sure, but it doesn't tell everything about the gastric cancer.
So, still staying on H. pylori, Sarah asks, what kind of H. pylori screening shows if you have active H. pylori versus if you have ever had H. pylori? If it doesn't show symptoms, should we also screen for it?
Yeah. Okay. There are there are three ways, three best tests, right, to determine if one is currently actively infected with the Helicobacter pylori. Uh, One is obviously biopsy, but then you have to do a bronchoscopy and biopsy. That's one. Another one is urea breath test. The other one is stool antigen test. So those three tests have a very high specificity and sensitivity. So those are all equally very good tests to do to determine if if the people are actively or currently infected with this bacteria. Now, there are serology tests, for example, but the serology test can tell if the person is currently infected or has been infected in the past. So, for example, um, if I know that patient is currently infected with Helicobacter pylori, if I were to do serology, I know the serology will be positive. But then let's say I treat the patient with antibiotics, a triple therapy, right? And the Helicobacter pylori eradication has been confirmed. So there's no more Helicobacter pylori in the person's stomach. Now, in that person, if I were to do serology, what do you think it will find? Serology will be still positive. It will be positive for a while, whether it's going to be for months or years. But I don't know about 10 years, but it slowly fades away, goes away, but it will be there still. So we use a serology. We can use a serology to decide whether the patient might have been infected in the past. But then that doesn't really tell the whole story, because if the patient had been infected 10, 20 years ago, had been eradicated, there's, the serology being positive at this time, 20 years later or 10 years later, is very, very unlikely. Does this answer your question?
So we have a question about someone's son. Her name is Lisa. She says that there's a very strong history of diffuse gastric cancer in the family. He is 33 and has CDH1 pathogenic mutation. She is stage four, but he is stage one. He is currently doing 6 months of surveillance at the University of Chicago. So far, they have found foci of signet ring cell cancer, specifically diagnosed as T1A, and he does not want to remove his stomach unless there's an actual mutation in signet ring cell. I'm wondering if there is any IHC or biomarkers, germline or somatic, that can help in any way stratify his risk, or ctDNA or RNA assay. Is there anything on the horizon?
Honestly, I don't know. That's something that that's not quite in the area of my expertise, but I have not looked into that. No.
Great, thank you. All right, and let's see, and we got a so Zena says her husband is first generation Korean but grew up here in the United States. And he gets his upper endoscopy screening and has gastric metaplasia because his father passed away at 52. He's following all the surveillance guidelines and he's getting a scope every year. Um, he still needs to have he still needs to have genetic testing as well, but what else can he be doing?
I think he's doing everything he can. If he's having, once a year or actually every other year, upper endoscopy screening, I think that is the way to do it. And I'm sure that when he receives endoscopy, the physician will routinely biopsy, randomly and on different parts of the stomach, because not like one or two biopsies, but at least like a five or six biopsies in the different parts of the stomach. I'm sure the gastroenterology, who's experienced with this, knows what to do about it. So I think he's getting it every year. That's fine. I mean, and he can have a genetic test. I think that's okay. I think that's all he can do, such that hopefully nothing will happen. But in the event any dysplasia is found, that will be really the early detection. And in these days, I mean, I've seen thousands of patients in a scope, and we see a lot of intestinal metaplasia, and some of them eventually, after 20 years or so, develop like a low-grade dysplasia or even high-grade dysplasia. And if they do that, and that's the time that you have to act on, actually endoscopically, right? We don't even have to, send the patient to surgery. We can actually remove the lesion once we find it, and localize it, and with endoscopy. So this is how I think screening and early detection can save lives.
Thank you. And can you expand a little bit more, because you talked a little bit about it, but dietary differences and environmental factors that might contribute to cancer
Yeah,
risk?
yeah. Well, that's a big important question. I mean, salt, nitrosamine, uh, these two actually come up as important dietary factors, risk factors, in stomach cancer all the time. And if you, there's an interesting story. If you look at, like what the gastric cancer in the U.S. Uh, it used to be one of the most common cancers, by the way, in America until like the 1940s. I don't know if you people know about this, but it used to be until like the 1940s, per 100,000 people, 40 plus people will have gastric cancer in the U.S. mostly non-Hispanic white populations. And these were gastric cancers found mostly in the body and the antrum, not in the cardia. It's non-cardiac gastric cancer. This was a time actually we knew nothing about the Helicobacter pylori because it was 1940s. But then, anyway, after 1940s and 50s, the gastric cancer incidence in the U.S. dropped down like straight. If you look at the graph, it's just amazing, impressive curve. It just dropped down. Right now, in America, with all the immigrant populations combined, we have about, six, maybe five per 100,000. That's the instance of a gastric cancer, as compared to like a 40 per 100,000. That's colon cancer, right? So, so what happened? What happened in the U.S. That the gastric cancer instance dropped down that dramatically over 10, 20-year period of time? And one theory is the refrigerator came about in 1940, 50s, 40s and 50s. Before 1940s, we had no refrigerator, right? So we used to use salt to store the foods, meats, and process the food and stuff like that. I mean, we have no proof on this. I'm just thinking, and a lot of people have been saying similar things, that might have been a factor, maybe. It's really curious to know what happened, such that the gastric cancer instance dropped down so dramatically in the U.S. Between 1940s to 1970s, for example. And so I think going back to dietary factors, salt I think isn't very important. Japan and Korea, they do have refrigerators, but they still use the old-fashioned ways of preserving foods. They use salt, they use fermentation, and all these products that are being produced by fermentations uh, could be, the etiologies that raise the risk for, gastric cancer.
How important is a primary care doctor in helping patients get a stomach cancer diagnosis?
Oh, thank you for asking that question. Very, very important because they are the gatekeepers, right? Um, um, I mean, I gave a CME 2 weeks ago to primary care providers. I mean, I was telling them because they are the ones who see all these people in the front. They are the frontliners, right? And it's critical that they know about this. Be able to, they have to really be keen about, H. pylori and other risk factors for gastric cancer. They should be aware of who are the high risk populations they can identify, and so it's very critical to educate primary care providers.
Thank you. And likewise, also a gastroenterologist, a general gastroenterologist as well.
Absolutely.
Another patient had said in those lines that my GI did not seem concerned about H. pylori at all when I was diagnosed. I was treated for this, but why don't doctors seem concerned or aware that their patients should get tested for H. pylori if this is considered a primary factor that can cause stomach cancer?
Yeah, I was going to say that too. Not only primary care providers, but especially, right, GI, gastroenterologist. There was a study published by people from Mount Sinai, I think, about 5, 6 years ago, maybe. And they picked about 90 some, well, a little less than 100, 100 uh, physicians in the Bronx and Upper Manhattan. Um, and I think majority of the more than half of them actually were gastroenterologists. And so they gave a quiz. If you see patients like this, would you do screen H. pylori? Would you do this and that? And the result was surprising, very surprising, that a lot of gastroenterologists, like this person who's asking a question, making a comment, pointed out, or not keen about this at all. So gastroenterologists need to be educated on this, and that's exactly the reason, one of the main reasons I returned to academics.
Thank you. How significant is having a healthy gut microbiome to digestive issues? There has been much discussion about probiotics and how they can help improve our overall gut health. Can you discuss the benefits of probiotics and how using them can affect our risk?
Yeah, I mean the benefits of a probiotics. The studies are very random, and I don't recommend my patients take this probiotic versus that, or take any probiotic. I tell them to eat good foods. I think that's best way to to make our guts stomach healthy. Um, take eat a lot of fruits and vegetables. I think that is a key to keeping our stomach healthy. Um, that's what I can say about.
All right, thank you. So another patient said, I have GERD, but my doctor just gave me a prescription for Prilosec and wants to see me again in 6 months. Is this standard and is this sufficient, or should I be asking for a scope or testing sooner?
Yeah, it depends. I mean, it's pretty typical. Patients coming with GERD, but depends on who the patient is. And let's say it's a non-Hispanic white person with no family history, who happens to be 45, let's say, and has GERD symptoms, sees a doctor. Very typical, the doctor will prescribe, proton pump inhibitors, one of those, right? And see how the patient does. And after treating it with with the PPI for 8 weeks, for example, and the patient still persistently has a symptom, then he or she can go ask for upper endoscopy. And depending on the insurance payers too, but there's usually no problem in covering that with the insurance too. But insurance issue aside, I mean, um, I think there's if GERD persists, despite 6 weeks to 8 weeks daily treatment of it with a PPI, I think it's important to seek out upper endoscopy.
Great. And for those whose insurance does not cover endoscopies, how would they advocate for themselves?
Um, well, that's a good question, but I don't know how to answer that. I mean, the how will they advocate for themselves if they have no insurance? So this is going to be a self-paid, right?
Or they have insurance, but it just won't cover an endoscopy.
Yeah, I guess, there are many places to get endoscopy, and depending on, which place, what kind of place it is, the payments and reimbursements, they're all different. So I think, if somebody has an issue like that, he or she can always seek out a different, very different places where he or she can get endoscopy. I think not only one or two places, but there are, because endoscopy can be offered in academic setting, for example, at the university hospital or the university affiliated outpatient endocenter, or it can be also offered in the individual private practice endoscopy centers, or actually some have the office-based endoscopy centers where actually in general you know co-pays or are would be much significantly less. So I think you can always seek out and check out different opportunities in different places.
Okay, so final question. If gastric cancer is considered one of the rarer cancer types, why should the general public care about stomach cancer?
Yeah, I wouldn't say it's rare. It's uncommon in certain ethnic populations, but it's very ethnic and very common in the more prevalent in certain ethnic populations as we went over, and because of that, it becomes a not only that one particular ethnic issue, but rather becomes a national issue. That's that. I mean, the health economics comes into play here also. So I think this is a important. It just becomes a public health issue. It is not a rare cancer. It is relatively uncommon in a majority of the population, but it is very common. It can be more common in specific the ethnic populations. So overall, it is a significant important. We have 30,000 plus cases every year, and many of them are being uh, diagnosed rather late. And what does this mean to economy? And not only what does this mean to the individual health and their families and community, but what does that mean also to the economy and to the nation as a whole? I think these are all important considerations that we have to have.
Really, thank you so much, Dr. Hun, for your amazing presentation and for answering all the questions. And thank you for everyone for all your participation, because all of your questions are going to be very useful for everyone who is going to be listening to this.
Thank you very much.
So yes, so please visit our DDF website for some of our upcoming events and programs listed here. This concludes today's presentation. We like to thank today's speaker again, Dr. Hun, for taking time out of his busy schedule. And we'd like to again thank our generous sponsors for making today's program possible. Our platinum sponsor, Astellas, gold sponsor, Merck, silver sponsor, Daiichi Sankyo, bronze sponsor, Arcus Biosciences, and the friend of DDF, Taiho Oncology. To view any of our recorded webinars, please visit our lecture library on the DDF website at www.wstream.org. I hope you guys have a wonderful night. This concludes this presentation.